new topic for me, infection control and secondary IOL procedures. So we have a few questions. One, is the risk of endophthalmitis higher when we do a secondary IOL? Second, why is it higher? Third, if it is higher, what should we do differently to ensure we control it? So in our series of 20 lakh surgeries, we had about 14,065 reoperations. The endophthalmitis rate in that series was of reoperations was 0.09%. And specifically, secondary IOL was about 1,654, and the endophthalmitis rate was 0.60. So in the study, our endoff was about 0.02, 2 in 10,000. So this is, of course, very high, almost like 30 times higher, very high risk in these eyes with secondary IOL. Later, Dr. Madhu Shekhar and others then shared their experience, again from Aravind, similar period, where again the secondary IOL was 1,277 eyes and endophthalmitis rate was 0.78. So similar endophthalmitis rate. So we do know that the risk is higher, not so much with the resurgeries per se, but more specifically with the secondary IOLs. Other resurgeries besides this, it was only about 0.02. And this is true not just with our series, but with multiple. There are a couple of studies from Medicare, one from Korea, and they all say the same. The endophthalmitis rate has been higher. This is a very recent publication from the Medicare services. So they have a huge database. Imagine looking at 97,152 secondary IOL procedures. And this showed endophthalmitis rate of about 0.3%. Again, very high. Some did have, some did not have MOXIE, which they don't have data about. And looked at two subgroups, which is secondary IOL implantation for aphakia and IOL exchange. And both the groups, it was similar, 0.35 and 0.28. Interesting was that those with anti-vitrectomy had a higher rate, 0.84. And why is this higher? Because not all cases with IOL exchange in their setting, a lot of the IOL exchange was done for refractive surprise, which they do a lot more there. So only about 40% in their series were because of the breach in the capsule or vitreous loss. So that is why in those patients where the capsule was intact, lesser endophthalmitis. Those who had anti-vitrectomy, it was 0.84, and posterior vitrectomy about 0.31. So this is again just to say that this is a phenomena which we see from multiple populations across the world. So, and this is the highest risk factor is secondary IOL, more than posterior capsule rupture, more than combined surgery, strap, cataract, or cornea procedures. So this is one of the highest risk factor in terms of endophthalmitis. Looking at, which is it true with all techniques or is it specific to one technique? Again, this one paper looked at 3,500 and odd secondary IOLs, and it was kind of similar, be it anterior chamber IOL, sterile fixated or sutured sterile fixated. It was similar, about 0.5%. And there are multiple papers which have like a series of 100, 150. And this one paper, like 122, iris claw, again 0.8. So it's like between 0.5 to 0.8, 0.9. That is what it is. And this does not seem to vary based on the technique. Of course, in some people's hands it may, but it seems to be a pattern across different secondary IOL techniques. So that is the first aspect. The other thing is, again, this is something which, we have to remember that secondary IOL, we normally try to not rush into for children because with children, of course, multiple factors. They are not completely, the eye is not grown and we don't know the final refractive status, unless, of course, it's unilateral myopia going in for amblyopia. But in this series of 21 eyes of 18 children of 4 years who had sterile fixated, they had 2 endophthalmitis. Of 20 eyes, 2 endophthalmitis is very high, so 9.5. And the reason being suture exposure. So this is true with, like I mentioned, with sterile fixated. I spoke about iris fixation. Also, I see the suture gives way. So with children, as much as possible, we'll try to delay any intervention if possible, unless you have to do it because you want to prevent amblyopia. Why the increased risk? One, because the anatomical barrier between the anterior and posterior segment is breached, and this is the main reason, and therefore there is access of the microbes into the vitreous cavity, and vitreous loss independently is a risk factor. PCR with intact vitreous phase is not as high risk as with vitreous loss, and the longer duration of surgery also increases the risk, besides the re-entry of the ocular commensals through the original wound. So that also is not properly done. It doesn't seal well. and that causes hypotony and influx of the surface fluid, again increasing the risk of endophthalmitis. So if you look at the sources of postoperative endophthalmitis, it could be from lid and lacrimal. So this is true for not just secondary IOL, but across, if you want to prevent endophthalmitis, you want to understand where the sources could be. Could be from the patient's own flora, from the lid and periocular region, any contaminated surgical instruments, tubing environment, any surgical complications. We spoke about breach in capsule and vitreous loss, poor or delayed wound healing or the patient's own flora, or the surgical supplies, BSS, ringer lactate, viscoelastic, anything which goes within the eye. So besides all of the factors we saw, what is it which is specific to secondary IOL? I'd like to begin with about advising surgery. So when we advise secondary IOL, we normally have to look at, Dr. Shivkumar nicely pointed out the different points. You have to look at the visual potential. And I also, my cutoff is also 612 is the potential. It's not that we don't do it if this patient has 618 or 624, but if that is the only eye or patient is aware or there are really strong indications, we don't just do it for any. The point is this. Sometimes I find doctors advise any FAK they see, which is thankfully not so common today than it was 2 or 3 decades or a decade back. So they say aphakia means we should do a secondary IOL. But what is the visual potential? Is the patient keen on it? There is no point. If the patient is comfortable, then why do we want to go and intervene? Before doing it, control the inflammation. That is why I like to wait for 3 months ideally. This is the ideal situation in my mind. If we are placing an IOL without capsule support, if it's a sulcus placement or not, then it's fine to go even within a month, 2 weeks to a month. Unless the patient can't come back or there is some other reason, or you're doing a combined surgery, combined vitrectomy with secondary IOL, or any of the other indications are there. A wound leak is there, so you're taking care of the wound exploration, suturing, and so there you can do it earlier because anyway intervening you can combine. Otherwise, good for let the eye heal. That actually helps a lot in how the patient does after the surgical procedure. So I tell them most of the time we'll do it after 3 months, and patients are okay as long as they know that they will have better vision after a couple of months. So try to delay if possible as much as you can. So pre-op consideration, of course, just like in any surgery, we'd like to ensure there is no nidus of any infection. We give topical antibiotics. We don't add anything extra. So anything we do 1 day prior and on the day, but 1 to 3 days is fine. And in addition, we add NSAIDs for all the secondary IOL. So NSAIDs can be given 1 day to about 4 to 6 weeks post-op because the risk of CME is high, nothing to do with endophthalmitis. And oral antibiotic can also be considered, though the literature does not have any evidence towards using oral antibiotics for endophthalmitis prophylaxis. I think this is a good, addition, good thing which we can consider. And whenever you give the oral antibiotic, try to give a similar antibiotic to what the patient is receiving topically. If you're giving Oflox topically, give oral ofloxacin. So this surgery under antibiotic cover is also something which can be considered. So the surgical factors, where do I place the incision? So if the surgery is recent, if you're going to do it within a few days or a few weeks, then maybe you can consider reopening the main, the original incision. If it's like say 2 weeks later or something. Otherwise, better to go with the fresh wound. Again, scleral corneal, it's difficult to open up the wound. A clear corneal may be easier. So there are those considerations you will have to do. Otherwise, always choose a new site because opening an old incision, we don't know how it was created. Is the corneal valve good? And you may have a different plane, so it is not going to work. That is when you will have hypotony and risk. So I typically like to create a new plane. Or again, if you're doing a limbal, it should not matter. You just go with one stab incision, it is fine. Keep the wound as small as possible if it is possible. If it is a rigid lens, obviously you have to plan a good 6 millimeter stereocorneal wound. If you can have an option of a foldable lens and then a secondary IOL, I would normally recommend doing a foldable IOL if there is sulcus placement or iris fixation, scleral fixation, if it is possible. So keeping the wound smaller also is good to have to maintain the architecture. Pressurize the chamber. So this is important. So like I said, one big concern is both extremes. You can have high IOP, which is very common after secondary IOL, which we especially see following sterile fixated techniques. but it can happen with any technique. The other extreme is hypotony. So we can't give them blanket AGM or anything. So you have to see them on the first post-op and then decide. So hypotony, because of the extensive vitrectomy or the wound is not created well. So always hydrate well, and for the safety, suture the tunnel. Especially if you're making it more than 3 millimeters, 3.5 millimeters, it's good to place at least one, or if possible, two sutures, so the wound is well secure. This is very, very important step because you have this continuous chamber, anterior, posterior segment, so it's good to have it closed. Prophylaxis, of course, we all know the importance of povidone iodine prophylaxis, 5% and 10% for the skin and periocular area. And if it is done recently, we normally have the assisting sister paint it, because they can be more gentle. You don't want to go and paint the eye and the periocular surface too strongly. Intracameral antibiotics, we used to, all our previous papers, our data was based on 500 micrograms. So based on the recent publication and input from Dr. Steve Arshinoff, we have now stepped it to 600 micrograms. So normally we will just draw 0.1 ml from Oromox, the ready-to-use intracameral or intraocular antibiotic, and inject into the eye. Today we draw in 0.12, which is 600 microgram. In eyes with capsular tear or secondary IOLs, we recommend using 750 microgram, which is 0.15, so more than what we normally do. Again, because it's a larger chamber. And as we know, Moxi is dose dependent. So if you give a less dose, it's not going to be effective, especially in these high-risk eyes. It's better to go with a higher dose. And again, we inject it in the very end after the hydration and the suturing is done. The other aspect is, a lot of the intracameral antibiotic, I think we in Aravind believe for any intraocular surgery, we give antibiotic. But the rationale is because numerous publications have shown that the anterior chamber contamination can be pretty high after routine IOL surgery itself, more so when dealing with secondary IOL, because the IOP variation itself can cause the transient gaping of the wound and therefore influx of the surface fluid into the eye, increasing the risk of endophthalmitis. So we would, so in this series where we looked at 20 lakh patients, half who did not receive intracameral antibiotic and half who received intracameral moxifloxacin, we found a significant reduction in phaco, about 6 times, and about 3 times in SICS. So endophthalmitis rate is about 0.01, or 1 in 10,000 for phaco and 2 in 10,000 for SICS. And in this same series, we looked at eyes with capsular tear, so total of about 28,000 eyes. And as you can see, the eyes with the PC rate have a higher rate. So it's 0.43 without the Moxi and 0.16 with the Moxi. So 0.02 becomes 0.16, which means 8 times higher if there's a PC rent. This is an intra-op complication. So this is what is also the literature. 7 to 10 times higher risk of endophthalmitis in eyes with PCR. And it is, of course, high with Moxi, it reduces, but even in spite of with Moxi, you find it is still much higher than eyes which did not have PCR. So even with the Moxi, you have a high risk. That's why the same principles follow. Looking at specifically at secondary IOLs, again, the endophthalmitis rate reduced by about 2.5 times, not as effective as it was in the eyes which did not have complication or a tear, who had underwent full surgery, but it's still a very high, 0.34 in eyes which received Moxi in secondary IOL surgeries. Other resurgeries, the low risk was very low. Not to say that we'll have to rush or not take precaution, but secondary IOLs is the only reoperation which has a much higher chance of endophthalmitis. So, but Moxi helps to some extent. So that is why stepping up the dose may help us, which we will also know hopefully in the time to come. What other surgical factors we'll consider? Wound closure is very critical to prevent hypotony. Thorough anterior vitrectomy. So there should be no strand or band of vitreous. Again, this can also be a factor for entry of the organism. Minimize trauma as much as you can, especially when many of these techniques are very complex. And every eye is different, every situation is different. And Dr. Shivakumar said we should know a backup technique. So we are also trying it in a most complex situation, and the manipulation becomes very high. That is why I said try this wherever you can in a wet lab setting or in eyes which are not that advanced. And if possible, not on your own complications, because that is when we get more jittery. But try to ensure that you, as much as possible, keep it to the least, the manipulation, because that reduces inflammation as well. And we know long duration increases the risk. So quick surgery is not always good, but slow surgery is always bad. We have to remember this, because we think it's okay to have the eye open for any amount of time, which is not fair for the patient or for the eye. And of course, all what we use, the instruments, irrigating solutions, must be sterile, and more care for the vitrectomy probe. Now, that is one extra device which we use in almost all secondary IOLs. And sterilizing it becomes very important to remember. It's a single-use device. And we'll have to know how to take care of a single-use device. So what are single-use devices? Right from like a phaco cassette, which almost all our hospitals or all our practices we use, is meant for single use, which means you're supposed to change it for every case, which we don't. We continue using the same cassette to the list until the end of the day. There may be some variations. Or be it our phaco tips are supposed to be used once and throw, but here we autoclave them and then use it for the subsequent patients. But and so the similar vitrectomy probe is meant for single use. And how do we know? We have that stamp there. What this means is the manufacturer has mentioned single use, not because it should not be used for second use, because they have not tested it for the second or the third or the fourth use. So they have only ensured its effectiveness and safety for the first. Second, third, fourth, the onus is on us to ensure we have the right protocol. So everything from reprocessing, including cleaning, inspection, disassembly, functional testing, disinfection, packaging, labeling, sterilization, and storage. So there's so many aspects to reusing a single-use device, which is like, and most important will be a vitrectomy probe in our case, because that goes into the vitreous cavity. So we say up to 10, most of the time 5 or 6 times is when maximum you can use, but maximum you can go in Aravind, we say as 10 based on our protocols of cleaning. Again, it has to be functional. If like Dr. Navneet showed, if the cutter does not move, obviously you'll discard, but it's also right after using, how are you washing it in the BSS, the cutting and the vacuum is being done. All of that also helps to ensure it's been done well. And you also have that reuse checklist. We have a stamp which tells us when was it last packed, which is the use number. So every time I have the assistant give me the probe, I'll ask them, the use ma, she'll give that information to me. So we know how many times it's used, and that also makes sure that the system is being followed as well. Post-operative, we will give them topical antibiotics for 2 weeks like we do for routine patients. And if there is any hypotony or vitreous incarceration, obviously we'll take them up as early as we can. And follow-up, it's good to have a follow-up in between at 1 week as well if required, because IOP spikes or any other complication that can be taken care of. And suture removal, we should not forget if you're placing a suture at the first month, because that can also be a reason for having a wound infiltrate and endophthalmitis. So to conclude, the right patient selection, rigorous adherence to sterilization and aseptic protocols, well-sterilized vitrectomy probes, pre-op iodine prophylaxis, attention to wound architecture, and intracameral antibiotics. All of this can help to control the endophthalmitis in eyes with secondary IOL. Thank you.